The future is not like Mount Everest, something waiting for us to arrive at. The future is much more like the Harbour Bridge, something we imagine, plan and build. If you don't imagine, plan and build the future, someone else will do it. So I'm going to tell you about the future, and I can tell you about the future with some confidence, because in the words of William Gibson, a science fiction writer has said, the future is here. It's just not evenly distributed. And the future is something that we make. And before looking at the future, I'd just like to revisit the past. And we're in the middle now of the third healthcare revolution. The first healthcare revolution took place in the 19th century. And it was driven largely by common sense. They didn't know about bacteria, but they were empirical. They saw what worked. They didn't wait for randomized controlled trials. They got on and did things. And some of the things that Maureen's been saying are so self-evident, so important that we should do it. The second revolution, Jonathan mentioned yesterday, has been, for my time in medicine, 40 years, and it's been driven by science, by engineers and physicists and mathematicians working with clinicians, not much with patients, and they've created these things on the right-hand side of the screen. And it's been fantastic. I mean, it has been astonishing. And the impact on the health of populations has been the same as the first healthcare revolution. But at the end of this fantastic period, every nation on earth faces these 5 problems: tax-based systems, insurance-based systems, private systems, co-payment systems, no co-payment systems. Structure doesn't matter. Structure doesn't matter. Harm, unwarranted variation, failure to maximize value, inequalities, and failure to prevent disease. And in addition, as Jonathan said yesterday, 4 new problems are coming. So, for the future, I'm going to tell you my solutions that we're working on in the NHS, and we've certainly got problems in the NHS. And the quote I didn't give Jonathan quite correctly. It's we may be making types of mistake we haven't even discovered yet. All the time we discover new types of mistakes. So here's what we're trying to do 10 things, and I'm just going to run through these quickly and let you know what we're doing and how I see us and Colloquium working together. Firstly, focus on value. You can always capture the paradigm in one word, and in England, from 1948, there was only one word: free. Healthcare was free. Then, in the 1970s and 80s, when Archie Cochrane published his book, we became effective. We became concerned with effectiveness. Then, in the 1990s, cost started to come in, cost effectiveness. And the last 10 years, it's been quality and safety. I wrote a blog in the BMJ called Bye-Bye Quality, Hello Value, based on the Everly Brothers song Bye-Bye Love, Hello Loneliness. Have a look at the blog. It's got a fantastic clip for the Everly Brothers. They must be playing in sort of Abilene or somewhere, you know, black and white. Many of you won't know who the Everly Brothers were, of course. They were really corny, but it was a terrific sound they had. Anyway, they bye-bye quality, hello value. Now, of course, you have to have quality, but the key issue is the relationship between outcome and cost. Now, outcome of healthcare is good outcomes minus bad outcomes. So you could say it's quality minus safety, to use the language. But it's the costs. We all have to get more willing to speak about costs. You can't have Geraint and his finance people over here and the clinicians over here. It's not, we have to all face up to this. I'm engaged at the moment with the ophthalmologist in the UK, and one group of ophthalmologists wants Lucentis, which is about 30 times more expensive than Avastin. Another group of ophthalmologists wants to do more cataract operations. And I'm saying to them, ladies and gentlemen, you have to make decisions. Because if you do Lucentis, the people are going to pay are people with glaucoma and retinopathy, not the taxpayer. You have to think about these things. And cost here, cost is not about money. Money is simply a means of transferring resources. One measure of cost I'll come back to is carbon. Another is the opportunity lost. So if you want to do more, if you want to prescribe Lucentis, then that is going to be paid for by people with glaucoma, with retinopathy, with low vision. That is reality. We've been engaged in these issues at the moment. And this is not a matter only of money. Secondly, we have to engage the patients. And we've had some very good examples of this. And this is as co-producers is the jargon. And here's an example of something that I helped a young doctor set up, which the BMA went completely crazy when we launched this. But this young doctor said, well, everyone is rating everything now. So we should get ratings organized. You're bound to get, those of you who are clinicians, you're bound to get somebody attacking on the internet. So if you've got 30 or 50 or 200 good ratings, then you've got something in the bank. And interestingly, the old guys like me didn't like it. But the young doctor said, yeah, this is bound to happen. But it's not simply giving feedback on experience, it's getting ideas from people of the sort that Muir was saying. And this, of course, works on the mobile phone. And we've got our first hospital signed up. And interesting, we're working with patient groups like the HIV Society or the Rheumatoid Arthritis Society, because they want to know where do you find a good doctor for HIV. Not everyone is good at everything. Half of clinicians are below average. It's a very, very serious problem that will